Hello, I am Dr. Gyanendra Sharma. I am a urologist and I will be talking about bladder injuries. The basic objective of this particular talk is to make the listener aware and the viewer aware about what causes bladder trauma, when to suspect it, how to diagnose it, and once you diagnose it, how to manage it. As is known, blunt trauma is the commonest cause of bladder injuries, with motor vehicle accidents being the commonest reason, up to a tune of 90% being responsible for bladder trauma. Of course, penetrating trauma in the lower abdomen can injure the bladder, and so also certain iatrogenic procedures can result in bladder injury. Now it's very interesting to know what causes a bladder trauma. Once we know that a pelvic fracture would cause a bladder injury, we think that it would be a bony spicule which would injure the bladder, but on exploration we rarely find such spicules. 63% of the injuries of the bladder following a road traffic accident are either on the dome and the side wall, 20% of the injuries are on the anterior or posterior wall, and only 10% of the injuries are due to a bony spicule, which means that bladder injury following trauma is rarely on account of laceration from a bony fragment. It is mainly a bursting type of injury. It's very easy to understand that the urinary bladder is having a lot of ligamentous attachments, and the shearing forces which act on these attachments during an injury would cause a laceration because of the pull and push that tends to occur. Initially, the bladder trauma was graded by the American Association for the Surgery of Trauma, but in 2004 a consensus was arrived at, and the classification has now been changed to a much simpler classification, and the committee has assigned a level of evidence 3 for this classification. Contusions, we honestly do not know the exact incidence of it, but these are the most minor forms of bladder trauma. Intraperitoneal rupture accounts for 30% of such injuries, and this tends to occur dominantly when there is trauma to a full bladder, and because of the pressure on the bladder, the tear is at the dome, which is the weakest and the most mobile part. Extraperitoneal rupture happens to be the commonest type. 60% of bladder injuries are extraperitoneal rupture. In this case, the tear is either at the anterior lateral wall near the bladder base, and this injury almost exclusively occurs with pelvic fracture. We see a combination of extra as well as an intraperitoneal rupture in about 10% of cases. Now, what are the immediate concerns with bladder trauma? In fact, it's not surprising that the bladder trauma is the least important whenever a patient comes with a vehicular accident. There are orthopedic injuries, fractures, a scenario of an acute abdomen, and because of the blood loss that has occurred due to multiple injuries, there is a high risk of mortality. So in this scenario, saving the life of the patient gets priority. The focus is on the much other major injuries, and of course in such a circumstance the geo injuries take a backseat. Hence, it's not surprising that 23% of the times the bladder injuries are missed at initial evaluation. In fact, a study in 2005 found that the average delay in diagnosing an intraperitoneal rupture is about 19 hours, and that of an extraperitoneal rupture is 6 days. The idea of this particular talk is to make the clinician aware that when we need to suspect this bladder injury so that such a delay is avoided. So the logical offshoot to this particular thing is, when should you suspect a bladder injury? If there is gross hematuria, suprapubic discomfort, inability to void, and a pelvic fracture with microscopic hematuria. In all these situations, one needs to suspect a bladder injury. 90% of these or more such of these patients present with gross hematuria. In only 10% of the cases, the presenting symptoms are quite non-specific in the form of some pain, tenderness, guarding, bruising in the lower part of the abdomen. So if a patient with vehicular accident sustaining a blunt trauma to the lower abdomen complains of gross hematuria, bladder injury should be very high on the list of suspicion. The specific symptoms which point that the bladder is likely to be injured are: 1. Inability to urinate, and in such a scenario, when the attending doctor puts in a Foley catheter, the catheter does not return urine, and this should light up the bulb saying this is likely to be some injury to the bladder. If at all such an attempt of catheterization is not made and the diagnosis of bladder injury does not occur, there would be extravasation of urine resulting in some delayed presentation in the form of fever, no urine output, peritoneal irritation resulting in features of acute abdomen, and an increasing creatinine. Now, a patient with pelvic fracture can have two types of fractures: an open book fracture and a closed book fracture. The open book fracture is more likely to be associated with a bladder injury, and a closed book fracture is likely to be associated with a urethral injury. Now, it's very important to be aware of a very significant statistic that 10% of these patients have also associated urethral injury. And whenever we see blood at the meatus or a perineal hematoma, the suspicion of urethral injury should be high in our mind. Now, when there is a major road traffic accident and a patient presents with gross hematuria, it's equally possible that there could be a renal injury. But if it is a pelvic fracture, then the chances that there would be a renal injury is only 2%. So the pyramid that I am showing here is, if there is a pelvic fracture, first suspect a urethral injury, then think of a bladder injury, and rarely, if both the things are normal, think of a renal injury. Now, once we have a suspicion of a bladder injury, the next rational question to our mind would be, how would we diagnose it? Of course, it would be using a cystogram. It could either be a stress cystogram or a CT cystogram, and we will discuss what is the role or whether there is any role or not of a routine CT scan to diagnose a bladder injury. Now, what are the indications for imaging? The consensus statement of 2004 on genitourinary trauma has stated that gross hematuria with a pelvic fracture is an absolute indication to do further imaging, while there are some relative indications in the form of gross hematuria without a pelvic fracture, microscopic hematuria with pelvic fracture, and sometimes even an isolated microscopic hematuria if clinical suspicion of injury is high. The gold standard by which a bladder injury is diagnosed is a stress cystogram. Now, what is a stress cystogram? Whenever a bladder injury is suspected, first do a ascending or a retrograde urethrogram to rule out the urethral injury. Catheterize only if the urethra is normal. Once the patient is catheterized, obtain a KUB film. Then fill the bladder to about 400 ml of diluted iodinated contrast, which is filled by gravity. The easiest way is attach a Foley adapter to the Foley catheter, connect it to an IV line which is connected to a 500 ml of normal saline bottle in which 2 ampoules of contrast are put. Once it goes to about 400 ml, stop. If a fluoroscopy is available, it would make the diagnosis much more easier. After this, the Foley is clamped, an AP film is taken, then the clamp is removed, the bladder is emptied, and a post-evacuation film is taken. There are two very important things one needs to remember. One, that false negative studies can occur if the bladder is filled to anything less than 400 ml in an adult. And secondly, if a post-drainage film is not taken, we are likely to miss a lot of injuries. These are two X-rays. The one in the upper corner is showing extraperitoneal rupture, and the one on the right hand lower corner is showing an intraperitoneal rupture. This is another stress cystogram where you can see that initially the bladder is filled partly, but when it is getting filled still further, there is extravasation suggestive of a rupture bladder. Now, this particular photograph emphasizes the value of a post-drainage film. On the left hand side, we are seeing a pear-shaped bladder because of the compression of the pelvic hematoma. absolutely normal looking bladder, but when a post-drainage film has been taken, it shows the leakage of contrast suggestive of extraperitoneal rupture. Now, a question which is very often asked and which comes to the mind is that when we see an extravasation of contrast, how do we diagnose that it is an intraperitoneal or an extraperitoneal rupture? Now, this becomes important because traditionally extraperitoneal rupture is treated only by catheter drainage in majority of the situations, while an intraperitoneal rupture requires an exploration. Now, the easiest way to differentiate between these two would be to draw an imaginary line connecting the two acetabula of the femur. Now, if the extravasation is seen above that line, it's an intraperitoneal rupture, and if the extravasation is seen below that line, it is an extraperitoneal rupture. These are representative X-rays of a stress cystogram which show an intraperitoneal rupture as seen on the X-ray on the left hand side and an extraperitoneal rupture as seen on the X-ray on the right hand side. Again, the same thing, that if you are joining a line connecting to the two acetabula, the extravasation above it suggests intraperitoneal rupture and the one below it suggests extraperitoneal rupture. Now, what is the role of a CT cystogram? Now, this is getting increasingly common because very often patients with multiple injuries are evaluated straight away with a CT scan, and so it's very logical that a CT cystogram can be done. Now, a CT cystogram is different from doing a plain CT scan. In a CT cystogram, once the Foley catheter is in the bladder is then filled with diluted contrast to 400 ml and a CT scan is done. Post-drainage films are not necessary because if there is any extravasation posteriorly, it can be picked up on a CT scan. Now, Peng et al. Have evaluated the efficacy of CT cystogram in 1999, and they found that even though if stress cystogram is a gold standard, the newer trend of CT cystography correlates quite accurately to the results of stress cystogram, and they proposed that one can probably compare the results of both the CT cystogram and stress cystogram as being equivocal, and they found that it is nearly 100% specific and sensitive. However, Deck et al. In 2000, in their study published in Journal of Urology, found that for intraperitoneal rupture, the value is comparable to cystography alone. And the advantage is that it identifies other injuries. On a CT cystogram, the way to differentiate an intraperitoneal and an extraperitoneal rupture would be, with the intraperitoneal rupture, the contrast is seen within the bowel, between the bowel loops, while the extraperitoneal perforation presents with what is described as a molar tooth appearance. We all know how a molar tooth looks. So if such an appearance comes, it is suggestive of an extraperitoneal perforation. Now, what is the role of a standard helical CT scan? Now, this is usually done using an IV contrast, and it's very important to realize that it misses bladder rupture 40% of the times, which means that this is not a very specific test to diagnose and is thus not acceptable as a diagnostic tool for diagnosis of bladder injuries. A very interesting sign described recently in a Korean journal of urology is the Sentinel clot sign. This sign is considered to be present when clotted blood greater than 50 Hounsfield units is seen abutting on the bladder dome. And if such a sign is seen, it usually indicates that there is an intraperitoneal rupture of bladder. These are the CT scan as well as the stress cystogram images of a sentinel clot sign. Now, these are ideal scenarios when we are seeing a stress cystogram and a CT cystogram being done. But such ideal scenarios do not exist in real practice, and we often come across situations when we are called upon to see a patient to rule out a urethral or a bladder injury and no such cystograms have been done. Now, how do we diagnose such an injury in such a situation? The simplest thing is we have been called to see the patient and see whether there is an injury, and we should see the problem. The simplest thing would be utilize a C-arm which is present in most of the operation theaters, And utilizing a C-arm, we can do an ascending ureterogram and then a cystogram. Sometimes it may happen that the patient has been opened up during a laparotomy and there is a suspicion of a bladder injury, and in such a scenario we can explore the bladder and confirm the injury. Now, what are the problems of imaging the bladder in patients with urethral rupture? Now, this is an important and pertinent question because the gold standard to diagnose a bladder injury is stress cystogram, which is possible only after putting in a catheter. And if there is a urethral injury, one cannot put in a catheter, so the cystogram is not possible. Plain simple CT scan is not reliable because it misses injury 40% of the times. So the only solution in such a scenario is that if the bladder is very full as seen on ultrasound, one can do a stab suprapubic. Otherwise, the best thing would be to do an open suprapubic cystostomy. Now, 10% of pelvic fractures have bladder rupture, which indicates that 90% also have pelvic fracture. This is important because a pelvic fracture is associated with enormous blood loss. Now, how do we manage such a patient? Now, we have classified bladder injuries. The first type of bladder injury is a bladder contusion. This is a diagnosis more by exclusion rather than by any radiological evaluation. A patient has a blunt trauma, he has gross hematuria, stress cystogram is normal. So in such a scenario, we are suspecting a bladder contusion, and then catheter drainage alone is good enough. Now, if we have diagnosed an intraperitoneal rupture, the patient needs to be opened up. A formal surgical repair using an absorbable suture material, either 2-0 Vicryl or 2-0 chromic catgut, should be done. The catheter should be kept for 10 to 14 days. Now, what should be kept for bladder drainage? A SPC or a periurethral catheter or both? Now, ideally I would suggest the use of both because in the early post-op period, if one of the catheter gets blocked, the other catheter would continue draining. The duration of drainage should be 10 to 14 days. Suprapubic catheter should not be inserted if it is likely to interfere with orthopedic procedure. And a very simple thing to be done, but which is very often forgotten, is that when we have opened up the patient and a bladder injury is being repaired, the bladder is lying in front of us, inspect the ureteric orifices, pass a 5 French ureteric catheter or a 5 French infant feeding tube through them so that you have confirmed that there is no ureteric injury. And a very important precaution to be taken is never disturb the pelvic hematoma, otherwise it might result in a significant bleed. How do we manage extraperitoneal rupture? Traditionally, it has been taught that extraperitoneal rupture is managed by catheter drainage alone. Do a cystogram on the 10th day, and if the bladder healing is perfect, remove the catheter. However, if you are seeing some leak, keep the catheter for the next 3 weeks, and by this time most of the injuries would heal up. But catheter drainage alone is useful for managing extraperitoneal rupture if and only if the conditions are ideal. How do we see that the conditions are ideal? Are we sure of the diagnosis of an extraperitoneal rupture? Is the drainage reliable? Is the injury simple? Now, if we manage a patient of extraperitoneal rupture with catheter drainage alone, the chances of complications are to the tune of about 26%. So when not to treat extraperitoneal rupture conservatively? First of all, if the catheter drainage is not reliable, which means that if clots are coming repeatedly, the catheter is getting blocked repeatedly, which might result in persistent extravasation, don't rely on catheter drainage, open and close the injury. If there is a bladder neck injury along with an extraperitoneal rupture, the chances of incontinence are very high. In such a scenario, catheter drainage alone is not advisable. Likewise, an entire bladder neck and prostate getting bivalved, a combined extra and intraperitoneal rupture of the bladder, an unstable pelvic fracture which requires internal fixation to prevent contamination of the orthopedic hardware, and a concomitant vaginal or rectal injury are indications where extraperitoneal rupture cannot be treated conservatively. Now, if the bladder injury is missed initially, the patient may present late, and this is on account of complications that occur because of the urinary extravasation, resulting in uroascites and subsequent peritonitis, paralytic ileus, and later on even sepsis. A bladder neck injury that is missed initially may present and cause very troublesome incontinence in the future. Now, iatrogenic injuries to the bladder may involve a gynecological, maybe on account of a gynecological procedure or a transurethral procedure. However, discussion of a transurethral procedure like a transurethral resection of bladder tumor causing a bladder perforation is not the focus of this particular talk. However, few important points regarding injury that tends to occur while operating upon other organs. The basic reason why such a bladder injury occurs while doing an open surgery or a laparoscopic surgery is reduced or inadequate exposure, excessive bleeding, or some anatomical distortion, especially adhesions because of previous surgery. An important thing to remember is that laparoscopy is associated with nearly 10 times more risk than a standard open surgery. Now, how do you suspect it? While doing an open surgery, if clear fluid is seen in the operative field or a bladder is opened and a Foley catheter is seen in the bladder, it's a clear-cut indication that the bladder has been traumatized. But while doing laparoscopy, it has happened that the assistants or the circulating nurse is vigilant enough to notice that the urinary bag has got distended with gas, which is used for laparoscopic procedure, and this distension of the urinary bag by the gas is called as a catheter bag sign and is a sure shot indicator of a bladder injury. Now, how do you diagnose such an iatrogenic bladder injury? Obviously, if you have seen a tear, then the diagnosis is no big deal. But if you are suspecting a bladder injury but are not sure of it, the first thing to do is put in a catheter, distend the bladder to about 400 ml with normal saline, and then instill 1 ampule or 2 ampules of methylene blue. And if the blue colored fluid is seen in the operating field, it's a clear-cut indication of bladder trauma. Now, sometimes this bladder injury can be missed during surgery, and again the presentation then would be delayed on account of the complications resulting due to the urinary extravasation. Now, delayed presentation, again the diagnosis would be by a stress cystogram or a CT cystogram. Cystoscopy by and large is not the first line of investigation. It is indicated if we are suspecting a foreign body or the visualization of injury would alter our management. And if at all a cystoscopy is done, it would be prudent to do a retrograde pyelography to rule out a ureteric injury also. Once the diagnosis is made of an iatrogenic bladder injury, the principles of repair are the same. Very often there is a temptation, if a laparoscopic injury has happened, to repair it laparoscopically, and definitely it can be done, but the person should have good degree of expertise to achieve such a repair. Now, what about a pediatric bladder trauma? By and large, it's the presentation as well as the diagnosis and management is the same as that in adults, but there are three important things which we need to remember. One, the incidence is lower than in adults. Second, bladder neck injury is more common, and this is important because it can result in very severe incontinence. And thirdly, dominantly such pediatric injuries are intraperitoneal bladder ruptures. So friends, what is the take home message? Well, if you have seen this TV show hosted by Salman Khan few years back, you would remember all the major points that I have highlighted in the talk, and this is the take home message. 10% of pelvic fractures have associated bladder injury. 10% of the times a bladder injury is associated with a urethral injury also. 10% of patients of bladder rupture do not have gross hematuria as a primary presenting feature. 10% of patients of bladder injury have only microscopic hematuria. 10% of bladder injuries will be diagnosed only on a post-drainage film of a stress cystogram. 10% of the times there is a combination of extraperitoneal and intraperitoneal bladder rupture. 10% is the incidence of associated bladder neck injuries. 10% is the incidence of spontaneous bladder ruptures. 10 days is the minimum time a catheter should be kept after repair of a bladder rupture. And 10% is the incidence of complications after bladder rupture. Thank you very much.